مظبوط خلاص كده.
Ready? Assalamu alaikum. Good morning, everybody. It's a great honor for me to meet you again. Second conscious sedation course. The conscious sedation course includes some guidelines designed to be applicable to procedure performed in a variety of setting practitioners who are not specialized or not specialists in anesthesiology. The purpose of this is to allow clinicians to provide their patients with the benefit of sedation analgesia while minimizing associated risks. These guidelines are intended to be general in their application and broad in scope. To classify depth of sedation, we should know what grades of sedation we deal with. First is the minimal sedation is anaxiolysis. Anaxiolysis means drug-induced states during which patients respond normally to verbal commands. Means, my dear, are you okay? Yes, I'm okay. Okay? Although cognitive function and coordination may be impaired. Ventilatory and cardiovascular function are unaffected. Okay? Second is a moderate sedation analgesia, which is called conscious sedation, that we will do it after we finish this course, inshallah. This is our target, is a moderate sedation analgesia, which is drug-induced depression of consciousness during which patient respond purposefully to verbal commands, either alone or accompanied with light tactile touch. So I'm telling him, are you okay? He will not reply. Gentle tap, are you okay? Are you okay? Are you okay? He will reply, okay? So I can repeat it more than one time. Tap gently on his forehead, something like this. No interventions are required to maintain patent airway. So, supposed to be no snoring. It's not deep sleep, just sedated. So, no interventions are required to maintain a patent airway. Spontaneous ventilation also is adequate. Cardiovascular function is usually maintained. What's more? Oh, it's deep sedation analgesia. We all not like to go into this plane of sedation because drug-induced loss of consciousness. There is loss of consciousness during which patients cannot be easily aroused. Not light touch, maybe pinching, maybe hitting him. So it's deeply sedated. Deep sedation, okay? Drug-induced loss of consciousness during which patients cannot be easily aroused but respond purposefully following repeated stimulation. Here, the ability to independently maintain ventilatory function is often impaired. Maybe hypoventilated, snoring, partial respiratory obstruction, apnea, complete respiratory obstruction. So patients may require assistance. Anybody can tell me what you do if we reach this plane of sedation? Any suggestion? You got my point? If the patient, while I am giving sedation, went to deep sedation analgesia, while there is ventilatory function is often impaired. What should we? Huh? Not go into intubation at all. Yes, maintain how? Before? BLS course. What? How to maintain open airway. Excellent, excellent, excellent. Head tilt, chin lift, or jaw thrust. Excellent. So next step, oral or nasal airway. If there is any secretion, suction. Last step, intubation. Okay. So with your hands only, you can maintain patent airway, as we all learned in BLS course. So how to maintain patent airway? First, head tilt, chin lift, jaw thrust, excellent. Oral or nasal airway, excellent. Suction, last. Okay. So patients may require assistance, as you told. I didn't say anything. You are telling all, right? Maintaining a patent airway, positive pressure ventilation may be required. May be required. If the patient is already apneic, we can take his breath. Cardiovascular function may be impaired. So as you noticing all, there is disruption of normal physiological process. Our target is to make the patient sedated, calm, but maintaining ventilatory function, maintaining cardiovascular function, not going into deep sedation or analgesia. So this is not our target, okay? Here there is general anesthesia, of course not outside the OR, is a drug-induced loss of consciousness during which patients are not arousable because we are doing surgical incision, so can't be aroused, okay? Even by painful stimulation, which is scalpel of the surgeon, the ability to independently maintain ventilatory function is often impaired. Of course, we are giving the ventilation artificially with the anesthesia machine or the ventilator. Patients often require assistance in maintaining patent airway. Post-pressure ventilation may be required. Cardiovascular function may be impaired. Protective airway reflexes includes the ability of an individual to counteract noxious events, especially to defend breathing paths against foreign material. Here the location where moderate sedation, analgesia, or conscious sedation is given. Dr. Hassan told a lot of indication. We will summarize here. Radiology department, okay, whatever diagnostic or interventional, medical special procedures, dental clinic, the emergency department, critical care units, echocardiology lab, cardiac cath lab, clinics as audiology and neurology, and pre-operative holding area. Here we will speak about patient evaluation. As any procedure to be done, we should take history and physical examination. Why? We can got points that will contraindicate the procedure. Not all patients allowed to give conscious sedation for non-anesthesiologists. Clear? So history for any medical or surgical problems, airway evaluation to detect if there is any risk for the airway, abnormalities of the major organ system, cardiovascular, neuro, respiratory, previous adverse experience with sedation, drug allergies, especially the drugs we will use, benzodiazepines, narcotics, okay? Focused physical examination, vital signs, auscultation, heart and lungs, evaluation of the airway, NBO status, and lab data. For airway evaluation, there is Malambati classification. It relates the tongue size to pharyngeal size performed with the patient in the sitting position. So the patient will sit in front of me. I am the practitioner. He will sit in front of me. Head position neutral. He will open his mouth. Okay. So performed with the patient in the sitting position, the head held in neutral position, the mouth is widely opened, and the tongue protruded to the maximum may vary if the patient is in supine position instead of sitting. So we are insisting to put the patient in sitting position. Sitting position. If he can't sit, so the evaluation will be wrong. If the patient phonates, falsely improve the view, because when I phonate, the tongue is depressed, the mouth opening is more wide, so it will give you false good evaluation of the airway. Okay. If the patient arches his or her tongue, the uvula is falsely obscured. Also, no phonation, no movement of the tongue. Here the Malambati score or Malambati classification. Here you can notice this is the mouth opening like this, exactly. Okay, this is the upper incisor, this is the upper lip, and this is the tongue, of course, in the lower side. Here, soft palate, then the uvula. This is the uvula. Okay, and this posterior pharyngeal wall. So if I visualized all these structures, mean soft palate, uvula, anterior and posterior pillars of the tonsils. So this is called class 1 Malambati. So okay, you can try with your family member or your colleague, you can try it. This is Malambati 1 or class 1 Malambati classification. For class 2, visualization of soft palate and uvula, but the posterior pharyngeal wall not as here. Okay, the tip of the uvula obscured and posterior pharyngeal wall also obscured. Class 3 here, I can't visualize the uvula, only the base of the uvula. So it's more obscure. Here, only the hard palate is seen, hard palate. No soft palate is visualized. Clear? Should I repeat? The second evaluation item is the ASA classification. It's the American Society of Anesthesiologists that put this physical status classification. You are listening, I think, to anesthetist or surgeon telling like this, ASA 1, ASA 2, ASA 3. You hear like this? No. Okay, first time. Okay. This classification of the medical condition of patients. So class 1 is normal, healthy patient like me, you, everybody. No medical problem. No history of any medical or surgical problem. So it's called ASA 1 or ASA class 1, normal, healthy person. Class 2, there is mild systemic disease. It's hypertensive, diabetic, but controlled, under control of medications. Under control. There is a problem, but under control. The blood pressure not high, controlled with treatment. Diabetes controlled with treatment, either oral or injection. Class 3, severe systemic disease, here not controlled. COPD not controlled, the patient is tachypnic, hypertensive, there is renal problem following the hypertension, something like this. Class 4, it's a severe systemic disease that's constant threat to life. So, suppose not be at home or walking, maybe in ICU. Class 5 here, moribund patient not expected to live with or without the procedure. So 5 classifications starting from lowest classifications: class 1, normal, healthy; class 2, mild systemic disease; class 3, severe systemic disease; class 4, severe systemic disease that there is constant threat to life, supposed to be in ICU; class 5, moribund patient not expected to live with or without the procedure. When an anesthesiologist or other specialist may be needed, so this is, we can call it contraindication for non-anesthesiologist to give the sedation. So if the ASA classification 3 or higher, so you can give ASA classification 1 and 2. Am I right? Okay. So ASA 1, you can give sedation, conscious sedation for that patient. ASA 2, you can give. If ASA 3, no. Stop and call an anesthesiologist to give conscious sedation. Okay? If there is airway abnormalities, means there is big thyroid, there is limited mouth movement, there is swelling here, there is bleeding, there is cancer in the airway, tongue, larynx, all these dangers for the airway, we should not go into conscious sedation. Morbid obese patients, it's also risky for non-anesthesiologists to give conscious sedation. Sleep apnea. What's sleep apnea? Do you know? Yes? Give me? You can?
Cessation breathing when the patient is asleep.
Who is you? Excellent. And cessation of breathing while the patient is asleep. Excellent. Excellent. Previously failed sedation, major allergy or anaphylaxis reaction. There is complex procedure. Sometimes the procedure is not in supine position, maybe in prone, head down, something like this. This is abnormal position. So not allowed to give conscious sedation for this abnormal position. So complex procedure, prolonged sedation needed. Sometimes cath lab extend time for 1.5 hours, 2 hours, maybe. So not allowed also to give the conscious sedation for that procedures. New procedure, same reason, because maybe prolonged. Unusual position, as we tell, unusual location. Sometimes chest physicians are giving bronchoscope. Doing bronchoscope needs sedation. So the bronchoscope will be in the airway. Yes? Whatever, it's for him, for simple procedure, but it's risky because it's around the airway. So, pre-procedure preparation. Of course, as any procedure will be done, there is informed consent. Preoperative fasting hours, there is clear fluids for 2 hours only. Clear fluids means water or what? Clear fluids, like, give me examples. Apple juice, excellent. Tea without sugar, okay. Coffee without sugar, all clear fluids, okay. Breast milk 4 hours. Infant formula, milk, light meal, or 6 hours. What's the equipment to be ready in the suite we are giving conscious sedation? Self-inflating bag and mask. Oxygen, we should have 2 outlets. Working suction, maybe 2 suctions. Pulse oximeter, ECG monitors, blood pressure monitors, capnometer, and pharmacological antagonists. Emergency equipment, airway kit, crash card, and defibrillator. What's the monitoring and documentation? SpO2, ECG. Post-procedure will continue SpO2 and blood pressure till discharge criteria met. Personnel to be available. The minimum number available personnel should be 2. One operator who will perform the procedure and one monitor will administer the drug. Here, procedure means conscious sedation, not surgical procedure or whatever. I mean here the conscious sedation procedure, giving the drugs, arranging for positioning, maintain airway, and the other is the monitor for monitoring of the airway, vital signs. Okay. The second individual will assist and with minor interruptive tasks. Both personnel must be credentialed for moderate sedation analgesia and of course for ACLS. Personnel who can administer conscious sedation include physician, dentist, resident physician, resident registered nurse. What's the discharge criteria? Patient will be discharged according to the Aldrich score. The patient must have score of 10, not 9.5. But anyway, 10. Because he will go out, maybe go home. So discharge criteria should be Aldrich score should be 10 on 10. Patients who receive reversal agents need to remain in the procedure area for at least 1 hour after the last dose. Why? Anybody have explanation? Patients who receive reversal agent, we are giving the drug as benzodiazepine or narcotics, benzidine, fentanyl. Okay? If we give reversal drug such as flumazenil, antidote, yes. Why are keeping the patient after receiving the reversal agents 1 hour in the recovery area after the last dose? Why? Okay, because sometimes the duration of the sedative drugs may be prolonged more than the reversal agent. So the reversal agent, short duration, we may need to repeat the antidote again, another dose. So he is apparently well, but after 10 minutes, 15 minutes, half an hour, may deteriorate again, sedated again. So if given reversal agents, we should keep him at least 1 hour following the last dose of antidote. Clear? Just enumeration of drugs given: mibridine, bifidine, fentanyl, ketamine, diazepam, midazolam. Of course, the most common drugs used is midazolam, fentanyl, followed by bifidine, ketamine, and the last is diazepam because it's prolonged duration. The reversal agents: naloxone, snarcan, flumazenil, is annexate. Thank you very much. Thank you. تفضل اسف.
Moderate sedation done by anesthesiologist from ASA class 3
3
or 4.
ايوه مظبوط.
طيب ASA 1 or ASA 2 can be done by
non anesthesiologist.
ايوه.
Privilege with ACLS. Privilege for conscious sedation and ACLS privilege.
طيب circumstances اللي تكون فيها ASA 1 و ASA 2 زي ايش؟
ASA 1 normal healthy person. As we told, we are taking medical and surgical history. Any medication, any diseases, any surgical procedures. We are evaluating the airway. Okay, fasting hours. If all clear, no contraindication, as we can proceed. You can proceed. Okay, normal healthy personnel or person with mild medical disorder as hypertensive but controlled, diabetes mellitus but controlled under medication. Okay. Yes. Have fun. Any other question? That means you are got all points. Yes? Can I ask? Huh? Can I ask? Right. I have patients. Huh? With me all? Okay. I have patient came from King Fahd Hospital for radiological procedure and asked you as physician or as nurse, non-anesthesiologist of course, to give sedation because the patient is irritable, can stay on the machine for CT or whatever. Okay. After taking history of the patient performed the same procedure under sedation, but he stayed in the hospital 2 days with some problems he can't remember. Should you will proceed to conscious sedation? Why? Why? But history of previous complication related the sedation procedure. Excellent. Another patient coming also from outside, but his height is 160 and his weight is 150. like this. Morbid obese, excellent. You will proceed. Excellent. Another patient coming, but he took breakfast since 2 hours. Full breakfast. You will proceed? Of course, yes. Because fasting hours, not okay. Another patient coming with a big bag with a lot of medications for heart, diabetes, hypertension. When I measured, the blood pressure was 170 over 110. His RPS 300 and plus. We proceed? Of course, yes. All right. In all these circumstances, anesthesiologists can manage because have the authority to manage these complications. But you, as non-anesthesiologists, you are limited to the simple procedure that will make no harm for the patient. Our target already is safe procedure. For safety of the patient, do the right procedure to the right patient or correct procedure to the patient. Okay? So it's not, you will not be a hero to do anything more than your privilege because there is will be sure harm for the patient. You got the point? Okay. Any other questions? Clear? Yes.
If ever there's an emergency and I don't have ACLS, then during the time the patient he's
I can't hear you. Sorry.
If the patient, if there's a situation that they need my help during the conscious sedation and I'm not ACLS, I cannot help with them attend to the patient in a life-saving situation.
Life-saving situation?
For
It's
example,
another
the
issue.
patient.
It's another issue. Life-saving, it's another issue.
We can.
It's code blue. It's code blue. Or RRT. I'll stop the stream first. I'll stop the stream first.
اي خلاص طيب
أيوة.
انتهى.
الله يحفظك. في لسه محاضرة يا أستاذ سلمى.
انتوا كمان
في واحدة كمان دكتور
الساعة
أيمن.
كم؟ انا حجاوب لك المدير.
الحين هو الحين على طول. جاي الحين.
Doctor, as per policy, doctor, if you're not if you're not privileged, the nurses will not allowed to perform conscious sedation.
If not privilege, you cannot.
Yes. So if I'm a nurse during that kind of situation.
Yeah, it's not, it's outside the scope of conscious sedation. There is an emergency. There is code blue or RRT. So there is life-threatening condition, not the procedure. We are speaking strictly about the conscious sedation procedure. Okay?
Because sometimes, doctor, during intubation, even elective intubation, you need to give medication.
Yeah.
That's what I'm asking.
Yeah, but outside the scope of conscious sedation. We are strictly speaking about conscious sedation procedure. You should be ACLS privileged and conscious sedation privileged. If anything, any problems occurs with the patient, we will call help from anesthesiologist, from the RRT, from the code blue team. You got it? So you are as part of the team, you will come to help, but not for the procedure. Okay? So the consultation procedure, we limited to 2 personnel who both are privileged for ACLS and conscious sedation. Okay, clear? Thank you.
Only one doctor?
only one ايه؟ انا بعتها لك كلها. شوف الواتس اللي انا بعته لك.
This one.
الواتس اللي انا بعته لك.
This one?
ده هو اخره 72. تاني الثانية النور الواحد.
This one, only one slide, yeah.
ثانية واحدة. بعتلك تاني النور. شوفي دي.
This one. Will I stream now?
Yes, yes.